conversation available to people afterwards publicly for people that aren't able to make it, or just so that you have notes from what was discussed. The other is we do have staff today from DC Health as well as DHCF who will be on the line. So just to run through quickly, Erica Walker, Sharon Mebane, Aisha Nixon, Victoria Alibi, and Cassandra Kingsbury, I believe, are all on the line from DC Health. And then Cavella Bishop, Mary DeVazier, Amanda Forsyth, and Angelique Martin are on the call from DHCF. If you have any specific questions for them, you can type that question in and just put their agency name after, so either put DHCF or DC Health in parentheses after your question, and then at the end of the call, we'll unmute them so that someone from their agency can answer your question. We did receive, what we asked was for people to submit some written questions in advance, and so we've received a number of questions. We're going to answer those. As always, people can type questions as we go, and we will answer as many of those as we can during the call. So Crystal Thomas is here in the room with me. I also have here in the room today Winslow Woodland, who's, as you know, the deputy for DDA, as well as Kirk Dobson, the deputy for quality assurance and performance management. People that are concerned, we are an appropriate social distance away from each other. So now Crystal will be reading the questions, and I'll do my best to answer or call on staff who are either here with me or on the phone to help answer any questions. And as I said, if you have questions that are specific for DC Health or DHCF, just type those in, let us know it's for them, and we'll reserve time at the end to allow them to answer those questions.
What is the status of the Appendix K and 1135 submission?
So we are working with DHCF on finalizing that, and we will be submitting it very shortly. And as soon as it has been submitted, we'll let people know. We'll publish what was in what's been submitted. What is in it?
What is in it? So next question is, what is
as
it?
Soon as it's published. I mean, I reviewed last week a summary of everything that that we expected to be in it. I will say that since that time, we have talked about, we did hear people's concern about issues regarding the training requirement for new staff. So there will be some flexibility on that so that people can bring staff on as long as there are adequately trained staff in the facility at the time that a person who hasn't completed necessary pre-service training. So we did address that concern that people had. Other than that, I think all of what we shared last week is the outline and the specifics of what was included in it. We've made some minor changes since then, and as soon as it's finalized and submitted, we'll share it with people.
Understanding that these items were submitted for Appendix A, but are they available for implementation now? Of course, there are some items that are taking place now, like day programs ceasing operations and redeploying to residential sites. However, in the remote support, are we being told by service coordinators that they are just discussion points and not approved to be done? With the anticipation of press items due to COVID-19, it is better to have the team prepared with plans and ready to go. Based on communication from service coordinators and service coordinator supervisors, this is not an option because they have not been told that it is okay to do so. Emergency backup plans may include the use of remote supports and technologies for health and safety.
So just so people are aware, and I think I'd mentioned this when I provided the overview for people last week, the effective date of our Appendix K is the beginning of the emergency, which was March 11, 2020. So it will be retroactive to that date, and you know, all the specifics of it we'll let you know as soon as the final document is submitted. I want to let Winslow speak to these issues regarding what people are being advised by service coordinators and their supervisors.
So prior to our adding the request in the Appendix K for the use of remote support, service coordinators were advised to follow the guidance, which did not include additional remote support. So we've gone from 20% remote support to 100% remote support as applicable to the individual. So that does not mean all services can be provided unilaterally using 100% remote support. It is individualized to the person's need, and we need to make sure that all providers are aware of that.
Could DDS have considered allowing day programs send their DSPs to residential, supported living, and host home facilities to provide services?
So we sent out guidance last week for day and employment providers, and the guidance essentially was to say that people based on, and it's now the mayor's order, at the time it was a recommendation, based on the recommendation that people not be congregating in one place, that we all limit our number of social contacts, that we increase social distance, that facility-based day services should cease. But we also said at that time a couple of other things. One, that all community-based day services, there should be a conversation about how those would continue to be provided. And the team should decide together how they could be provided and how they could be provided safely for everyone involved. For folks who have a day program and a residential program, we expect that they would just pull their staff from one program to the other. And then we had also suggested that day providers and residential providers work together. One of the flexibilities in our Appendix K is if you work for someone else, you can immediately start working for the other provider. There are also some providers who have worked together to come up with an agreement so that the day provider provides services during the day for folks who are in that residential provider settings. So those are issues that are dealt with individually and between providers. But we've tried to provide guidance so that you can kind of work through what all the options are and will be with our Appendix K.
Did DDS consider that this current solution benefits residential, supported, and host home providers while severely hurting day providers?
What we considered in making our decisions was ensuring the health and safety of the people we support and of all the staff who work for them, and taking all the measures that we can to reduce the number of contacts that people have, your staff as well as the people you support. Those are the considerations that we took into account. As I did say, and I think I mentioned in my summary last week, our Appendix K will include retainer payments so that we can try and help out those day providers, who are going to not be able to be providing services for some, where they will be able to bill a particular rate for people for whom they were providing services and they are not now providing services.
Did DDS remember that day providers will still be held to same expectations of performance once the pandemic is over?
Of course. I guess what that goes to is the issue of our retainer payments, being sure that what we're trying to do through retainer payments and the purpose of retainer payments is to try and help providers make it through this really difficult time.
Without any form of financial support, how does a day provider pay administrative staff, insurance, rent, and other recurring expenses during COVID-19 pandemic?
All of that will be addressed when you see the Appendix K that goes out. You'll see how the retainer payment is structured so that you can see what is left there.
What hope message do day providers have to their DSP communities that they are still holding on?
I guess a couple of things. One of them is, as I said before, we have some providers where the day provider has worked with other residential providers to say, if you need additional staff, I can provide supports with my staff there. There are some residential providers who have declined that offer because, and in fairness to them, they are doing their very best to limit the number of people that a person has contact with. But the other thing is, for DSPs who are not working right now, there are providers who could benefit from their services. And so, while we are right now in the middle of probably the worst unemployment that not just in any of our lifetimes, but I think ever. There'll be a demand for DSPs. So the folks who work for day providers who were working in a facility-based program and can't continue to work, or who are working for a day provider that isn't also a residential provider, so they're not able to work, there should be plenty of opportunities for them to work for one of the residential providers in this interim and then to transition back.
Could BDS have urged residential, supported, and host home providers to discuss on individualized strategies to continue services according to CDC rules and regulations?
Actually, the purpose of our call last week, and unfortunately, just because of some technical issues we have, there isn't as much opportunity for people to talk with each other, but we have encouraged providers to talk with each other. For one, on individual, in terms of services for each individual person, the team should be talking about how to continue to meet that person's needs during this time. And then, you know, we had encouraged and continue to encourage providers to talk to each other about how they can work together. Because, you know, I really appreciate that for day providers especially, there is this real, I mean, there's this gap. You're not going to get income for this period of time, but there is the opportunity then. You've got residential providers who suddenly need to provide more services to people. And so it could be that that gap for you can fulfill a need for them, and that can help you bridge this.
New hires don't just jump in and run the ship. They take direction from the more seasoned staff anyway. It would make more sense to train folks up on the job. They would not be passing meds. They would be helping people to cook, clean, and doing the less person-based aspects of the job. Of course, they would be trained on the person, but making them all complete all the elements of phase one before being able to add to support is not going to help with the crisis.
And we heard that from all of you, and we have made adjustments in our Appendix K, which, as I said, as soon as we submit it, we'll be making it public. You know, there will be the provision that there has to be a fully trained person on site working with them at all times, but we are waiving all of the pre-service requirements, except in certain circumstances where there would be concern about health and safety, like CPR, like, you know, MANT, CPI, these kinds of things, where if a person has behavioral health needs and the person has to have the MANT or CPI training, we can't waive those kinds of things. But we really are working to make it as flexible as possible so that we can address any workforce issues.
DSPs may have expired certifications and trainings, and there's no way to train them back up because the trainers aren't available to do the training. What is worse, having someone who has lapsed training at least working or having even fewer DSPs who can work because of a technical lapse in certification.
So our Appendix K will include provisions that CPR in this interim could be done online. For MANT and CPI, for initial, it's a problem, but for recertifications, we can do online. And MANT has extended their recertifications out to May 31st.
Has CMS approved any waivers to allow for remote supports for day services?
We have included now, so we have included remote supports for some of our day services in our Appendix K. And as Winslow said before, when we look at remote supports, we're trying to be as flexible as possible to allow them for up to 100% of the time the support's being provided. But that is, you know, with the understanding that the team agrees that the person's needs can be met and that we can ensure health and safety of the person while providing the services remotely.
If day program services are permitted and the person is only able to engage remotely for less than authorized hours due to attention span or other challenges, will the SFA be adjusted accordingly?
No, and so this is there's a couple of important points here, because as we go into this, the service coordinators, first of all, what I didn't mention before, when we make any of these changes, we are going to be amending the ISP. So, you know, the service coordinator, and they have been able, is my understanding, to turn those changes around very quickly. The service coordinator is not going to, so for example, if someone was in a facility-based day program and now they're going to do companion services in the home, they are not going to end date the authorization for the day program, because once this ends, the person will continue receiving that service again. They're just going to add the additional service. Now, what this means is, and for example, if someone has been authorized for up to a certain number of hours of service, billing is done based on services provided. It's not done based on services authorized. So it's essential during this time that the billing offices are getting reports of actual services provided, because a provider could really get themselves in trouble if they're billing authorizations that are out there where services were not provided. CMS considers that Medicaid fraud. So it is essential that people, you know, we will not be adjusting SFAs down. The SFA will say authorized for up to this many hours, and the invoices should reflect the services provided.
Could DDS have considered offering day programs the opportunity to support the persons they are currently authorized to provide service to via Skype, Zoom, or other means?
That was included in the guidance that we sent out last week.
Will employment readiness and supported employment service providers be able to provide remote services?
Yes. And it's, you know, the same caveat, to the extent they can. To the extent the service can be delivered effectively and ensure health and safety of the person, then yes, those services could be provided remotely.
Has consideration been given by the district to authorize payment to day program providers under waivers while closed, taking into account an average monthly billing cycle for services previously rendered prior to COVID-19 to assist providers in retaining staff until the emergency ban is lifted, or a flat retainer for 60 days for the same purpose?
We will be addressing retainer rates in our Appendix K, and as soon as we submit it, we'll provide the details to the day providers so they can bill appropriately.
We seek clarity on understanding the retainer payment for those day services participants duly supported in residential and day supports. Are day service providers still required to provide quarterlies and attend meetings for the participants? If so, how would the provider get payment for such oversight services for the program coordinators and the day program?
Those issues have been taken into account when we considered how we structured the retainer payment.
How does the retainer payment for day providers work? What is covered? Is there a specific format that is to be used? What information has to be included? Who do we send the invoice to?
So, you know, I'm sort of like a broken record. As soon as it's finalized and submitted, we'll share it. And if there are questions about how to do the invoicing, those could be answered either by DHCF or our waiver staff.
Beyond the retainer payment, are there any other provisions to provide day providers with compensation during the pandemic to ensure continuity of services?
No, what we're doing is doing what we can through the retainer payment.
What will DDS approval constitute for service changes, ratio changes, et cetera? This cannot be a prolonged process with service coordination. It should be a simple communication from the Q or program manager who indicates this is an agreed-to action plan by the person supported because of an emergent support need. SCs should not need to hunt down family members for input and debate the need. They are not in the fray. Providers need to be able to reserve the right to implement safety protocols to meet the needs of the person as soon as possible without waiting on a SC. If providers do not hear from DDS within 24 hours, can the change just be implemented?
The answer to that question is no. I did say it last call, and I think I sent an email to representative of the Provider Coalition that in the event that a service coordinator is not able to do their job effectively and timely, that I was to be called. Keep in mind that a lot of things are changing at a very fast pace, and this is a change for service coordinators as well as providers. So I don't want any services delayed, but I'm not going to say automatically implement a decreased staffing ratio or any other significant change compromising that person without input from that team, which includes the guardian, the service coordinator, and or the family members. And I understand that this can take time, but I'd like to be involved in all of those where staffing issues are involved so that I can track that and make adjustments appropriately.
What is being done by DDS to obtain or circulate a letter that indicates that DSPs are essential workers? I have sent DDS 3 samples to work from.
So the mayor's order that was issued this past weekend addresses essential critical infrastructure workers. And that order indicates that essential, that people should not be leaving home except for to attend to essential functions. And included in those essential functions are functions performed by essential critical infrastructure workers, which doesn't say DSPs, but if you look at the description, it covers DSPs. There are a number of functions that continue during this current crisis. Grocery stores remain open, gas stations remain open, social service agencies, programs that provide food, shelters. Clearly, all of our providers need to have their support workers, their direct support professionals get to and from work. Other staff may need to get to that home. Medical personnel need to get to work. So all of that is addressed in the mayor's order to be clear that those staff are expected to continue, and then a request that people who are not attending to essential functions not venture out into the community in terms of, because we addressed this on our call earlier today with the community, there isn't a sort of shelter-in-place order that doesn't allow you to leave your home. The issue is that people are being discouraged from interacting with other people. What is stressed in the mayor's order is the importance of maintaining social distance, so that if people in a home wish to go out to take a walk in the neighborhood, to get some fresh air, that is perfectly fine, as long as they are making sure that they continue to maintain social distance from each other, so that if you have someone who requires someone standing too close, it may be that person's ability to venture out into the community could be limited. We had posted on our website and sent to providers guidance regarding the measures that social service workers should be using when interacting with people. There's a tremendous concern in the district that personal protective equipment be conserved for healthcare workers who will need it. And so there's very clear guidance about when those things are needed and how to ensure safety when providing services. So we've sent that to providers. We've posted it on our website. I'd really encourage people to review that and to review it with their staff.
When will there be confirmation of funding for overtime and actual costs of services that are being provided by overtime staff and through temporary staff?
We are working these issues out with DHCF, and as soon as we have some final answer, we'll provide it to you.
What is the possibility of funding for hazard pay for workers?
Same answer.
Since WMATA will be closing 17 additional metro sites on 3/26, would there be opportunities for providers to obtain services from NTM to pick up limited groups of staff, less than 10, at a time for a nominal fee for staff who rely heavily on public transportation?
I mean, I could leave that question to DHCF. I don't know if they could respond to it near the end. My expectation is no, because MTM is transportation for Medicaid beneficiaries. I will say, coming into work using public transportation, while the number of buses were fewer, the stops on the metro were fewer, I was still able to get to work using public transportation and using all the necessary precautions, not sitting near people, doing my best not to touch the railings while I was in there, making sure not to touch my face till I got to work and washed my hands. You know, you need to be talking to your staff not only about how to ensure their safety while they're at work, but getting to and from work.
The universal pay leave reimbursements for providers who have been paying into DOES leave till July 2019, is my understanding that DDS was at least going to do a true-up of the cost back to the beginning of FY in October 2019. Where does that stand, and when will it be included as part of the reimbursement rate?
Well, it's currently provided as part of the reimbursement rate in this year. The question about last year's funds, we can't answer right now. As you can imagine, we're taking a very close look at all of our FY20 expenditures. The district has had a severe hit in terms of revenue. Spring is a very big time for revenue in the district. So we are looking at that. It is on our radar, and you know, along with the questions raised earlier regarding overtime, possibility of hazard pay, having to use temp staff, all of that, we are working all of these issues through with DHCF and OCFO, and as soon as we have an answer, we'll provide it.
Will we be recording the forum to share with providers?
Yes, as I indicated at the beginning, the forum is being recorded. And we will work out the technology to make it available to people.
Was there an email asking providers to write a contingency plan of operations during COVID-19? Did this include day providers? What was the purpose of this plan? We have not received that email.
So that email, so we sent emails out twice to providers. Once, I believe it was March the 6th, when we asked all providers to review their plans and update them to address COVID-19. And then on March the 13th, we sent something out asking that they submit those plans to us by the 17th. We have only not received two. The quality resource specialists are reaching out to those two agencies. People should make sure that you're checking your spam or your junk mail to make sure that it's not going there. The emails that came to you would be coming from dds.qapma@dc.gov or dds@dc.gov. So you might want to check there, but these went out to all service providers, day and residential. And as I say, we've gotten responses from all but two.
When online applications are required for jobs, can we assist the person and bill for it?
And this is a question as I'm looking here. I believe this is a question for RSA because job development is RSA. As people who provide services through RSA would be aware, RSA pays through milestone payments. It's not an hourly rate. And so the requirement for RSA is that during the job development phase, there be three face-to-face contacts per month. The guidance that we sent out last week said that that face-to-face could include telephone conversations, but that it was essential that in the monthly report that you file, that you document the substance of the conversation so that it's clear that it was a substantive interaction and not simply a phone call to schedule a meeting later or a phone call to say, did you log on and file that application? But an actual substantive meeting with the person, and the expectation is that there would be 3 meetings within a week and that those meetings could happen remotely.
How do we write and get paid for encounters when we are doing job development and a consumer wants to talk about their anxiety and COVID-19 concerns?
As I said, if it's a substantive conversation, and frankly, if a person is saying, I'm too scared to go to work right now, I have these concerns about COVID-19, seems to me that that could be part of helping the person prepare for work or even make a decision that this isn't the best time to go to work. But you would just document those conversations the same way that you have been documenting in your monthly report the contacts with the person.
Are we allowed to bill for conversations over the phone with the person as well as potential employers?
Yes.
Due to COVID-19 issues, does RSA plan to offer relief funds to its providers? If so, what do providers need to submit to qualify for this fund?
There is no plan to do that at this time.
If there's a centralized number through RSA where consumers and providers can go to get advice on managing stress, staying in contact, especially to address consumers' concerns about going to work.
The people should call their VR counselor. As I said, almost all of our staff are teleworking, but they are all working. They are all available by phone, and so if someone has these kinds of concerns, they should speak with their counselor. If they need a referral for services after that, the counselor can help facilitate that.
Okay. This is regarding remote meetings. Can providers count phone meetings with clients as face-to-face meetings at this time?
That is exactly what it says in the guide. If people could look at on our website, on the first page of the website, up at the top, there's COVID-19 updates. Click on that, and you'll get to the page where it's got all of our updates. There was an update sent last week to all day and employment providers, and it does answer these questions and says, you know, if you're going to continue working, you should do so remotely. To the extent that you're able, you should absolutely ensure that you're keeping a safe distance from people, but really job development should be done exclusively remotely. And yes, you can, you know, as I said, the RSA billing is milestones. It's not hourly billing. And so as long as you have 3 substantive conversations in a month, you can be paid for that month.
Can we assist with the development of resumes over the phone?
Absolutely, and there are other ways you could do it as well. You know, you could do some ways online to share a document back and forth, but absolutely, and that would count as a substantive conversation.
What are options to provide service if the person does not have a computer, internet access, or technological knowledge?
This is why we expanded this. From my perspective, face-to-face has always included Skype, FaceTime, you know, anything. If you are having a substantive conversation and talking with the person, we have been clear in our guidance last week that it also would include phone calls as long as you document the substance of that phone call and it's a substantive conversation.
Are we allowed to provide service over the phone for job development?
I think I just answered.
Are there suggestions to completing intake appointments with new clients? Currently, the intake paperwork takes 1.5 to 2 hours, and this is a long time to ask clients to be on the phone with us.
You could break it up into more than one appointment. I know that RSA has been doing, we've been doing our initial intake with people over the phone, so we have been able to work that out. People can, you know, drop documents off for us, or they can scan documents to us, or they can mail documents to us for eligibility purposes. You know, I would say be creative and use technology as best you can.
How can we ensure clients have resources necessary to continue working with us?
If the clients had an issue regarding, you know, these days I don't hear about people having issues with minutes as much as I used to, but if a client has an issue with having access to appointments because they only have limited minutes, they should talk to their counselor. In the same way that we would provide transportation to come to you, we would provide minutes to come to you.
Are there any specific formats or requirements for reports if we perform online or over the phone services? It's
the exact same report. You should just document that in the documentation of your interaction with the person, that it was over the phone, and then document the substance of the conversation to clearly reflect that it was a substantive conversation.
Are 3 contacts per month still required during this period to qualify for billing?
Yes.
Is the rule for 3 face-to-face contacts being transferred to phone contacts? And if so, if consumers have an Obama phone and don't want to or cannot download apps such as Zoom and Google Hangout, how do we engage when they are worried about using up their minutes to speak with us?
ask them to talk with their counselor about getting a maintenance check to add minutes.
How will transportation issues for consumers who work beyond the metro and bus cutoff be resolved?
That would be a case-by-case basis, because quite frankly, I can't think of, I mean, I know for myself, I have to walk quite a distance now to get a bus, whereas because the bus that normally comes to my house is really there for school children and they're not going to school. So my bus isn't there anymore and I have to walk to get the bus. And the buses don't run on the same schedule that they used to. I think this is a good opportunity to plan with the person, to do the trip planner through WMATA, to look at how they can get from one place to another. While certain metro stops have ceased operations, bus lines have cut back. Often, I think it's on a Sunday schedule. There's limited coverage. People should be planning for that. And those are the kinds of things that we talk to someone about when they're planning to go to work, which is how do you plan for how you're going to get there? Keeping in mind that no matter what we pay or agree to pay to help the person get to work for a couple weeks, once they start working, they need to be able to pay this themselves ongoing. So, you know, I would strongly discourage a person, depending on their income, I guess, you know, the sort of level of income for their entry-level job, I'd strongly discourage someone from relying on Uber or Lyft to get a car ride to work. I think that part of preparing someone to work is helping them prepare in these difficult times for how they'll get there.
And that concludes the questions that we, actually, no, there's a couple more. Oh, no, that's it. Okay. So now we are looking at the questions that you all submitted.
So we're going to start with DDS questions, and then, because we're just trying to figure out, there's a little bit of a technical glitch trying to connect our colleagues from DHCF and DC Health. But we're going to start and answer the DDS questions, and then we're going to try to unmute the line totally, see if that will work. But first, let's just answer DDS questions. So for DDS,
when issuing new service authorizations for companion services in lieu of the day program, what guidance has been given to service coordinators in terms of staffing patterns? Service coordinators are keeping the same staffing pattern regardless of the circumstances in the residence. As an example, if a client had group day have, they will only issue a group companion 1 to 3, $10.28. When the circumstances in the house will make it 1-to-1 staffing by default.
So I did answer this question in a private text to this person because I didn't know if we'd have time, but I have been working with certain providers on this issue. And as I explained the example, if there are 3 people living together and 2 of them work or are working or did not have the need for companion, that would be a companion 1-to-1. We will not add companion 1-to-1s to the entire house unless each person in that house had a 1-to-1 need. And please, if you have those cases that you're unsure of, you feel free to reach out to me at 202-730-1618, and I will help you through those.
so for the next series of questions, I'm going to unmute Amanda Forsyth from DHCF in case she wants to add anything. These are all regarding Appendix K and retainer payments. So Andy's going to speak to them, but we'll also unmute Amanda.
Can you provide any more detail on the retainer payments in Appendix K regarding day programs? What is covered, funded?
As soon as the Appendix K is finalized, we'll share it. We'll share it with people.
How is day program going to be compensated for the loss of revenue?
Same answer. And I don't know if Amanda's in a position to provide more detail, but my response right now would be we're very close to submitting the Appendix K, and I'm sorry that we can't share it immediately, but as soon as it's submitted, we will share it. And all of our Appendix K, as I said, will be retroactive to March 11th. So people could start billing, you know, whenever you would bill for March.
And this is Amanda from DHCF. I'll just add that the Appendix K once submitted will provide the basics of the services for which a retainer payment is possible, and any other payment related changes for the duration of the emergency. We will also be issuing some hopefully helpful guidance in terms of the logistics and like operationally how you bill for that. The procedures for billing from the provider perspective won't be included in the Appendix K itself, but we will be publishing some corresponding guidance. So just as a heads up, that will be coming, if not at the same time, then shortly following the submission of the Appendix K.
Thank you.
The reason that there needs to be a separate letter communication from the district is so many people can transit to and from work. If the workers have something in writing to carry, they will feel more secure in going to work with an authorization rather than worrying about being questioned and trying to rely on just saying their health care. We also have other jurisdictions where DSP lives, so someone living in Montgomery County saying that they are okay to transit to DC because in DC healthcare is essential are going to have issues.
Providers are encouraged, if they are concerned about this, to issue a letter to people that work for them, referring to the mayor's order indicating that their staff are essential and need to get to work, and it would be on the provider's letterhead saying they've been identified as essential workers by Maryland and DC. Cite to that and provide them whatever letter you feel is necessary. Buses, in fact, are free right now. People walk in the back door of the bus for a Metro bus. So the guidance that we've gotten so far is that the order provided by the mayor is adequate.
When issuing new service authorizations for companion services in lieu of the day program, what guidance has been given to service coordinators in terms of staffing patterns? Service coordinators are keeping the same staff.
I think we had that question asked and answered.
Yep. Okay, next. Okay, we've answered that question. Is there a plan for in-home support retainer payments?
I did answer that in a private text, and the answer is no.
I can't imagine what the reason for that would be, because in-home support should be continuing.
We didn't stop in-home supports.
I would like to know if there is a possibility to allow clients to give verbal consent to VRC for services acknowledgement. I know that procedures require a client to sign many documents during the intake process and later IPE. However, during those unusual circumstances we are facing, if there is a way to make this process more remote accessible. Our agency had received permission from DBH to have our clients consent for services over the phone when documented appropriately. I was hoping we could have similar process with RSA. This would allow us with continuation of services as well as engage new clients and employment services.
So RSA has been doing remote intake interviews with people, completing the application process, and there are then a couple of different ways that they can get the signatures they need. They either print it out and mail it to the person so that the person can sign it and mail it back in, or they can take a picture, send it to the person, they can sign and send the picture back to us, and we can scan that picture in. So, you know, depending on the person's access to technology, there are different ways that we can get the signatures we need, but those things are not delaying our process.
Okay. So
Okay. At this point, I'm gonna ask everyone to just please mute their lines. Everyone on the phone, I'm gonna delay for 30 seconds while everyone mutes their lines. If you're on the computer, please mute your computer and your microphone at this time. Well, don't mute your computer, mute your microphone at this time. So I'm gonna give 30 seconds for everyone to mute either their microphones on their computers or their phones. That is the only way we will be able to get DHCF and DOH to provide any feedback they would like to or answer any questions. Okay, I'm going to unmute lines at this time. If there's too much feedback, we're going to have to mute them again. So just please mute your lines. Try one more time. So unfortunately, people are muting their lines, so we can't really get any feedback. I don't know if the folks from DHCF, I have a few people on the line, but not everyone. I can't identify who specifically would like to speak. So I think that the folks from DHCF want to respond to the questions in the chat box. Currently, the question that's been posed for DHCF is if day programs will be opening by the last week of April, our person supported will have to continue receiving active treatment at home. Do residential providers continue to pay the day programs as per the day programs contract, or is the contract void due to the emergency and residential providers do not have to pay the day program? So we're going to see if DHCF can just respond to that via the chat box, and we'll read the response.
He's going to manage our social.
We're also going to, there's another question for DHCF here. We're just going to go ahead and read it, so you can respond as well.
What's the status for processing any HCH applications for direct deposit payment? We submitted our request and all required documents months ago. We are still receiving paper checks, which have to be picked up from our registered agent. At this time, more than ever during social distancing, we need our payment to be deposited into our bank. Thanks.
So I'm going to unmute Mary Devassier from DHCF in case she wants to speak, as well as Erica Walker. Those are the people that show up on this list. I will unmute any other folks that I can find.
Okay, for the first question regarding the active treatment contract, that is a specific contract that the provider has, the day provider has it with the residential provider. So understanding the validity of that contract, both those entities, they have to work together on that, because we don't determine when you terminate payment for one person. So whatever that is in that active treatment contract, you would have to honor that. In terms of the payment, the direct deposit, I would have to take that question to Don, who's on the call, and we will get an answer back.
Other questions? So other questions for DHCF? Does the District of Columbia Family and Medical Leave Act, DCFMLA benefits, and the Federal Sick and Safe Leave Act run concurrently, or is it in addition to DCFMLA? That was for DHCF.
Unfortunately, I will not be able to answer that. We'll elevate that to Angelique.
I know organizations, this is Amanda, have different provisions in terms of how they want people to utilize those different sick and family leave benefits. So again, I don't think that's within our scope, my scope at least, to answer that question specifically without knowing more details.
Okay, there was a question that came in here for DOH. And several folks have been unmuted. What guidance do you have regarding the use of cloth or washable masks? And so far we have from DOH unmuted. Actually, I don't think anyone from DOH is unmuted. So if DOH can respond to that. Hi, yes, we can. Can you speak up just a bit, please? Hello? Was that Isha? We're not hearing you right now. I'm sorry. I think that was Aisha Nixon. I'm not sure. So if DOH could please respond to that question of what guidance do you have regarding the use of cloth or washable masks in the chat box, that'd be greatly appreciated. There's another question here for DDS.
Before we do that, I do want to refer people back. DC Health has provided guidance, which is on our website. You can also find it on their website regarding safely working with people as a human service worker, as well as for medical staff. Our staff generally are not medical. They would be the human service workers. So please take a look at that guidance that has been put on our website. It was put there yesterday, I believe. That was intended to really help people understand.
And the guidance, or just you go to DC Health?
I'm sorry, could you repeat?
So I'm seeing a question about Medicaid renewals. So Medicaid recertifications, I assume is what you're referring to here. Medicaid recertifications from March 1st through May 31st are being extended during this period. So anyone whose Medicaid recertification came due March, April, or May is being delayed. So at least for those, we're in good shape.
Can you repeat the website again? Okay. So I think that's what we have so far for questions for in the chat box.
So our website, just so people are reminded, is dds.dc.gov, and right up at the top of our website, you see COVID-related, a link for COVID-related questions. And you can also go to coronavirus.dc.gov for all of the current information regarding coronavirus and how the district is responding.
So we will, we're assembling these notes from last week and this week, and we'll have them out to you before the next meeting next Friday, but we're working on them currently, as well as trying to figure out a way to send out the recording of this meeting. This meeting was recorded. It's just we're trying to make sure we can put it on our website or some other means, but we will be sharing the information before next meeting. So another question has come in for DC Health. It says the guidance from DC Health for direct human services staff doesn't address instances where sick people who didn't meet criteria for hospital admission will be advised to quarantine at home. Given that our DSPs may be asked to support people in home, what guidance is there for providers in the event we cannot obtain additional PPE? And I'm going to try to unmute Aisha again. Maybe she could provide some
If she isn't able to, we've actually been able to coordinate this week where we had a person who lives in their own home who did test positive. We work very closely with DC. DC Health intervenes in any case where a person's diagnosed. They do step in and make sure that the people in their home are safe. They check to see whether the person can be provided for in the home where they're living or if they should be moved. In the event they need to be moved, DC Health helps with identifying a safe place they can be moved to, and they also ensure the safety of the other people in the home. So the guidance that we provided doesn't address that because that is a specific instance where a person is diagnosed. DC Health does have folks who really step in quickly, provide reassurance and really good support to people. Fortunately, we have learned this through just one person that we've had diagnosed so far.
Another question came in from DDS-RSA. Can job developers continue working with clients even though they are currently not CESP certified as of now?
There's been no waiver of rules for RSA regarding any provisions that are in the Human Care Agreement. So if this was required a month ago, then it's required now. So whenever RSA sends something to you asking you to return it, they are expected to and should be including a return envelope with postage so that you can return it to us. Because we need those signatures to be in the file in order to get reimbursed for the services we're providing. So we should make every effort to make sure that we're doing that. When we get audited, they look at whether we have these signatures.
Another question for RSA, do expired IPEs need to be signed, or is there an extension for them as well?
No, they would need to be signed, and we'll go through the same process. An IPE doesn't really, I don't know that one expires. An IPE should be reviewed once a year. So if it's time for the IPE review, those reviews, there are a number of different ways to do them. So, but if any signature is required, the signature would be obtained. And it is not at all unusual. VR counselors have always done a lot of the work that they do. Once a person is doing their job search or once they've started working, VR counselors are in touch with them on the phone, or if they're away at college, they're talking to them on the phone, having them scan documents to them. So it's not unusual to have to get documents into us without ever coming into our office.
We have 4 minutes left, and one last question is for DDA. How do we go about amending ISPs and getting new authorizations in time if the work status of the people we support has changed and cannot provide support with the current service authorization?
All service coordinators are working remotely. That would be a conversation, a telephone call, and a meeting with the person's team. It's no different. We're just doing it from different rooms. To the extent that you have challenges, please reach out to myself or the person's supervisor, and we'll gladly walk you through the process. Okay, so I think there was some information that was shared by our partners at DC Health. I'm just going to say it out loud for everyone. Erica Walker shared that guidance for healthcare can be found at coronavirus.dc.gov. That's coronavirus.dc.gov. And the phone number to contact is 202-576-1117. Again, 202-576-1117. We have one last question for DDS. Can DDS officially state when day programs, facility-based or community-based, could be resumed if the person chooses to return to day program services? Per the mayor's order, the public health emergency is currently in effect through April 24th. Schools and government are to reopen on April 27th. Is the DDS current stance on day programs? And if mayor orders the public health emergency extended, should we assume that this includes day programs?
Yes, we should. And, you know, the current order says through April 24th. And as we move forward, the circumstances will dictate. We will continue to do our best to, as timely as we can, post all this information on our website. If you go to dds.dc.gov, right up at the top, you can click there and you'll get all the updates from DDS about our services and our guidance that's provided.
There's one other question. What is the expectation for clinicians to submit evaluations for the ISPs, given there is no opportunity to evaluate the person?
Currently, we are, as has been stated, limiting social contact. And with regard to ISPs, we have been approving without certain clinical documentations ISPs. I'm really asking that clinician reach out to me or provider reach out to me directly, because clinicians are able to perform, some clinicians are able to perform remotely and others are not. So I'd like to just have that person to reach out to me, Winslow Woodland at dc.gov at 202-730-1618.
There's one last question.
Can some evaluations be done via technology?
Yes.
Yes, and various professional groups have gotten guidance from their licensing boards about what can be done remotely. So absolutely, yes.
So, you know, we're sorry that we weren't able to get DHCF and DC Health fully participant in this meeting because of technical difficulties. However, please submit any questions you have for DC Health or DHCF to the dds.quapma@dc.gov email box. That's dds.qapma@dc.gov, and we'll make sure to forward them and forward them along to the appropriate party.
So thanks for the conversation today. As I said earlier, we'll be doing this every week. So next week, same time, about 12:05. And if questions can be submitted during the week, please submit your questions by Wednesday so that we can make sure we have an answer for you by the time of the call. And we will talk to folks next week. Thank you very much.